Our last panel of the day is beginning now in the panel room. Leading the way, featuring Mike Beal, Alan Hash, Lance Hassell, David Mills, Owen Hammond, and moderated by Ted Wahl.
All right. Good afternoon, everyone. Welcome. It's great being here with all of you today. My name is Ted Wahl. I'm the CEO of Healthcare Services Group, and I'll be your moderator for today's panel discussion on the future of the industry. Before we get started, though, I did want to, especially in collaboration with the panelists, shout out and give a big thank you to Hershey and the eCapWest team for creating such an amazing event that brings us all together. So, eCapWest team, thank you for that. The work you do is important, and we appreciate you for doing it. But I think even more importantly, now that the panelists and I have had a chance to really scan the room and see so many familiar faces, we wanted to thank Hershey for honoring our request of only allowing the most astute long-term and post-acute care professionals into our session today. So quality, not quantity, is what we were striving for. So on behalf of the panel, thank you, Hershey and team. We asked for quality and you delivered in spades, so thank you for that. Joining me for today's conversation are 5 industry-leading CEOs with over a century of combined experience. They have founded startups and led billion-dollar enterprises. They have expertise in both the for-profit and non-for-profit space. They have acquired, divested, they have survived and thrived. And currently, they're leading and managing tens of thousands of employees across the Western United States. So it's a great honor for me to be able to introduce our panelists today. From my left to right, Mike Beal of Care Initiatives, Owen Hammond of Cascadia Healthcare, Lance Hassell of Cambridge Healthcare, Alan Hash of Avalon Healthcare, and David Mills of North Shore Healthcare. So welcome. Please join me in giving a warm welcome to our panelists today. The future of the industry. What does the future look like and how will we deliver it? We're going to break this conversation today into 3 parts. Part 1 will focus on the near-term challenges and opportunities facing the industry. There is no shortage of discussion points on that, I assure you. So think the next 6, 12, 18 months, what issues are facing the industry, what issues are relevant. That's where we're going to organize the conversation. The second part of our discussion, we're really going to focus on and imagine what the future may look like 5 years from today. It's a great opportunity for our panelists to be able to share their vision for the future and discuss some of the priorities they have today in planning for tomorrow. Finally, we're going to wrap up today with some rapid-fire Q&A between the panelists and me, and very much looking forward to that. So audience, please stay active, stay engaged, fill us with energy up here so we can leave here with some meaningful takeaways. And with that introduction, let's get into it and started with a discussion on workforce challenges and staffing. According to BLS data, there were nearly 1.6 million nursing home workers pre-pandemic, over 244,000 jobs lost during the pandemic, and only 60,000 jobs have recovered since. At the current pace of recovery, it's estimated that nursing homes will not return to pre-pandemic levels until 2027. Alan, how do these workforce data stack up against the realities of what you're seeing on the ground?
Well, that is what we're seeing on the ground, is we are seeing these large number of open positions. And it is a challenge, especially with the mandate that has just been proposed, of what it will really do to our industry. But the staffing has been challenging. Through COVID, it was more than challenging. It feels like that we have come out of the worst, though. I know that about January of 21 was the peak of what we saw of the staffing challenge. It has improved significantly since that point, but there is still a shortage that is just not met. I know as we look at our results for 2023, we've been able to reduce the agency by about half of what we were spending in January to what we spent in August, and that trend seems to be very positive, but it is still a big hurdle and one of the biggest barriers for us being able to recover from the census and the other needs that we need in the industry. The cost of labor has also escalated much faster than the reimbursement that we are seeing come back on the Medicaid and on the Medicare sides.
Well, it's interesting because you think of workforce availability, and Alan, you shared with me a personal anecdote earlier in the day about a daughter that you have that was interested in getting involved and interested in the healthcare industry, and maybe sharing with the group that story, because for me, not only was it powerful, but I think personal anecdotes are often the best to help shape policy and shape the future.
Sure. I live in a girl's world. We have 3 daughters and 5 granddaughters, but my youngest daughter, she graduated from high school. She went to a fairly large high school with a little over 800 students in her graduating class. She obviously got her brains from her mother because she did graduate number 1 in her class, and so she was a bright kid, all through school, straight A's, did very well, great ACT scores, goes off to college, does well in college in her first couple of years, and applies for the nursing program, and as happened, she did not get into the nursing program. And it was very common that it takes 2 to 3 years of applying to actually get into the program in the nursing school. And so it just shows that there's a challenge where we have people that it is a great profession. It's one that we have many young people want to get into the nursing profession. It's an honorable profession. And yet there's barriers for being able to, for many people to be able to pursue that. I was talking with one of our DONs just this last week, and she teaches at a university as well. And she was saying that the challenge is that so many people that she has in her classes have waited, just like the example I shared, 2 and 3 years to get into a nursing program, that she says a B student in the first year or 2 of college is not going to get into one of these university nursing programs. So ultimately, until we fix this supply and demand issue of having enough people, and we have enough young people that want to go into it, I think, we just need to create more access for them to be able to get into these programs and to move forward. End of the story, my daughter's now running a pharmacy, and she's doing very well, but she did not go into nursing.
Thank you for sharing that, Alan.
Yeah.
David, the majority of North Shore's facilities are in Wisconsin. Are you seeing similar trends in Wisconsin to what the national trends are? And you too have a personal anecdote. I'd appreciate if you could share that, because I think it adds context for the conversation.
Sure, yeah. We operate 52 skilled nursing homes and 11 assisted living in Wisconsin. And we are seeing the same thing. We have about 400 openings. We started our own internal recruitment department, a staffing company where we fill about 500 shifts a week, but it's not nearly enough. And I think, I remember writing a paper in college when I thought I knew everything about long-term care. And the title was, "There's a Crisis in Healthcare." This is 1986, so I'm dating myself. And I said there were too many regulations, not enough reimbursement, and too little staff. Does that sound familiar?
Soothsayer, right?
I'm like, my Lord. Yeah, and I'm 34 years in, or whatever the math is, and here we are wondering if we made a difference at all or not. And we have. There's absolutely no question that the care that's being delivered to our seniors is in a much different place than it was. But those challenges still remain. We need to see this profession, and we need to promote this as a wonderful career. And I think oftentimes we end up playing defense, and we've got to do a better job. And I've heard other panelists talk about being more aggressive in telling our story legislatively and in the papers and getting people in buildings. And we've tried to do that really, really aggressively at North Shore, to be much more aggressive, because we have a very compelling story to tell. A couple of them that I have, 2 of them actually. I serve on a board called CHASE, which is part of the University of Wisconsin-Eau Claire. They graduate 60 students a year with a degree in healthcare administration. They do a year internship. And we find within 2 or 3 years, those 60 licensed nursing home administrators, half of them leave that profession. And that's a problem. My daughter, as an example, went through an AIT program and was an assistant administrator for one of our facilities. And about 3 years in, she called and said, "Dad, you're nuts. I can't do this anymore." The 24/7, the expectations. And the reason that I bring this up is there are young, aggressive, talented people that want to be in this profession, and we've got to pave their way and help support them in a less punitive, more collaborative environment. And we're challenging with that. We also have many of our department heads, and we have identified them. We have operated in many rural communities, towns of 800, 1,000, 1,200 people, census of 40 or 50. We have department heads that are licensed or that are degreed social workers, 4-year degrees, have a number of years of experiences, and want to become an administrator and don't have the ability to do that because the governing body doesn't allow them to sit for their nursing home exam, even with different courses to take. So I think one of the big challenges and opportunities we have is how do we pave the way to make this a profession that young professionals want to be in and succeed and stay? And how do we pave the way for some of our more senior people that are in our buildings today that want to grow and allow them to be leaders? Because for us to solve the staffing problem, I really do think it really starts with retaining and developing our local facility leadership, our EDs and DONs.
They're all great points, David, and I think it's empowering for me to hear you say that, because it not only speaks to, it's oftentimes when we talk about staffing, it's almost like they're just not there. What I'm hearing is that oftentimes they may be there, or they are there. We just need to kind of shape their pathways to success along the way. So that's great to hear. Owen, when you think about staffing, not just for Cascadia, but even more broadly, some of the challenges that are in the environment, have there been any learnings or innovations? What have you seen as the opportunities that maybe we can leverage into the future?
Yeah, I think as we've seen a lot of operators turning more into the regional model as opposed to the big national chains, you have a unique opportunity to kind of really focus on the states that you're in. And so, David, Wisconsin, and I think one of the things people want in the workforce right now, especially the young people, is they want to feel there's a purpose. They want to feel connected. And so building that culture, really developing it, making sure that they feel connected and heard, that's usually where you're going to get a lot of your good employees, is usually through somebody that really enjoys working there. And so I think the opportunity is, again, the companies that really double down on being very transparent with their folks, having a clear line of communication, letting them know, hey, we don't know the answer to everything. We need your input to help us figure these things out. And some of those initiatives that you put in place as far as like finding talent often come from the people that just got hired, and just asking them, hey, why did you decide to come, work with us? And they'll tell you, hey, I have a buddy that works there, and he really enjoys the Pizza Friday that you do or whatever. And it's not about pizzas, and it's not about that kind of thing. It's really about, do they feel heard? Do they feel like they're making a difference and connecting with those people at that level? And it's hard to do that with the funding that they've got out there nowadays. It's hard. The margins are very small. And so people trying to invest into that, it almost seems like they get worn out at some point and they have to back off of those things. And then the narrative in our industry is pretty negative, and so why would somebody want to come work in our industry? Because all they hear is the negative, and we need to change that narrative out there.
Well, it's interesting you talked about kind of local. What I heard was local focus, local empowerment. Everything happens within the four walls of a given community, which is antithetical to the staffing mandate. And at the risk of burying the lead, we're going to spend some time here talking about that staffing mandate. And still on the topic of workforce challenges, though, CMS released the proposed minimum staffing rule last Friday in a Friday news dump, right? How bad a form was that? But a Friday news dump. In an ACA press release issued shortly thereafter, Mark Parkinson stated that, quote, winning means a rule that we can implement or stopping a rule that we can't. I continue to believe that we will eventually win, end quote. Mike, recognizing there's still a long road to hoe here in terms of litigation, comment periods, elections, what does winning, assuming there is some form of a rule in the future, what does winning look like or mean to you?
Well, the easy answer is that it goes away, but I don't think that was one of the options, was it?
Well,
so I think that we've all been in this industry for a long period of time. I don't think anybody would disagree that more staff is better than less staff. And I think the challenge of hiring staff is one set of issues, but having no reimbursement tied to this is really the issue, right? Everybody's trying to figure out how they're going to make their facility viable if they've got to add staffing. And I represent a group of facilities that was as I entered the state of Iowa for the first time 3 years ago, they told me that we were the lowest cost provider, lowest acuity provider in the state, which meant I also had the lowest staffing ratio. So for me to get up to those numbers is a significant lift. And how do I make that viable in an environment where the reimbursement is not going to keep up with that? And I think if there was a mechanism, which there probably isn't an easy mechanism because most of our funding is through Medicaid, which is a state-by-state issue, to pay for it, we probably could work towards the challenge of actually being able to fulfill the requirement. But right now it's a win-lose proposition. You got to do it, and we're going to penalize you for not doing it, but we're not going to pay for it. And so at least a pay-for strategy would be a significant help in this endeavor.
I remember reading an article, I think you were quoted in Skilled Nursing News as saying how important time was to this equation as well, seeing the 3 to 5 year for urban, suburban, and then the 5 years for the rural facilities. Did that fit into what your expectations were? Is that enough time, assuming it is fully funded?
I think it's enough time. It's interesting. I was talking to somebody else earlier today. Miraculously, a week ago, we don't have a state minimum in Iowa. I know some states do. We had surveyors walk into a building for the first time. We had it happen in 2 different buildings, and then I conferred with others had the same experience. Surveyors walked in with the PBJ report that they were given, and we're going to cite for not staffing to where we had flags on the PBJ report. And we talked the surveyor out of it. After 3 days of intense conversation, the surveyor went back to their supervisor and said, we don't think there's no need to cite for this. And they got overruled because CMS made a directive that any tag or any one flag on the PBJ report for the last 9 months was to be cited, no option. So there's already a mechanism being built for this very punitive approach to the staffing issue. And so as you look at the timing, yes, it is significant that there's a delay, and hopefully with litigation and or a change of administration, there may be some even further timing on that. It does soften the blow, but it's like anything else. I think it's going to get stuck, and then it's hard to get rid of it once it's there in regulation.
Well, it's interesting. You mentioned that some states do have minimum staffing, and states like New York, Massachusetts, Illinois, Rhode Island, Connecticut, Vermont, Maryland, and the District of Columbia, right? So, Lance, California, I didn't want to leave that one out either. You're one of the largest operators in the state of California, the Republic of California, as I've heard it kindly referred to at different times. You've dealt with minimum staffing requirements that were very close to the federal proposal. How are you navigating the minimum staffing currently, and what say you on the federal proposal?
Well, through COVID, staffing was really challenging anyway. Regardless of the mandate, you had to still manage with just taking care of patients. There's waivers. So the state of California enabled us to have waivers for the mandate. So we were able to have a waiver to get us off of the 2.4 expectation for CNAs, and if you could manage a different waiver, you could actually get it lower down your 3.5 expectation. I don't know about on the federal mandate if there's going to be a waiver. I think that's still in question if that's going to happen or not. But in California, there is a waiver process, but it's rarely approved. So you're still having to navigate around it. Not only that, but you're getting audited on an annual basis, and if you're not hitting your mandates, you're getting sanctioned. If you miss more than 3 days outside your mandate, you get $25,000 fine, or it can go as high as $50,000 fine if you missed a mandate. So that's significant, and I don't know how the federal will look at this now on the mandates. Relative to a mandate with California, we're at a 3.5 now and a 2.4 with CNAs, but there's no mandate on RN. Where I'm worried with this new mandate is RN staffing. Where we're going to find these RNs, they're not out there. I mean, if I look at just Cambridge now as a company, we're running about 0.3 RN staffing. Now, if you add 0.55, where are they going to come from? We got to figure out where they're going to come from. How are we going to do it? Is it going to be reducing our overall CNA or LVN mix to hit the mandate with the overall, but still continue to keep in California mandate? It's going to be a challenge. I'm worried about finding the RNs.
Well, I mentioned, we talked about California, and I mentioned some of those other states in all seriousness. I don't know is JJ Rabinowitz here? JJ, how are you? I listened in on your panel that I guess you were inserted as the moderator on. I thought you did a fantastic job, but the title of it was Collaborating and Advocating Across States. And understanding that the federal kind of ACA strategy is anchored to this idea of 10,000 comments, it was interesting to me how important the state advocacy will be on this. And, I want, last question on this topic for the panel, to put it out there to see who wants to react to it. But it'll be interesting to see how do states like California or the District of Columbia or Massachusetts and Connecticut align with or collaborate with Idaho, Montana, Washington State, Wisconsin, these states Iowa that may have nothing in common culturally, politically, or otherwise. And the fear would be that there could be a break in the armor somewhere along the line, and that these other states that I listed somehow focus more on boutique issues that are more important to them as opposed to the greater good. So I didn't know, panelists, Lance, maybe you could have an initial reaction to that since you just followed up on the California.
Relative to greater good, I feel bad for the states who have not had the mandate hit them yet. Like California, we've been lucky enough to have to staff up for it.
Say that one more time. A little louder, right? We want that on record.
It's not been easy, and I hope as the states start to get this going in CMS, I hope there's a waiver opportunity for people who can give them the opportunity to ramp up, but also be able to justify their means for not hitting the mandate. Hopefully that can happen. We can collaborate throughout the state lines on getting something like that established. I think that'll help a lot.
Go ahead, Alan.
Yeah, I would just add to this that one of the biggest challenges with the mandate is all facilities are not created equal. They're all different sizes, they're in different locations, they're in different markets, they're different niche focus, and they're just not the same. And so to put a mandate that applies to the entire industry, it just doesn't make sense. Even their own study showed that it didn't make sense, that they couldn't come up with an exact, precise number of what that should be. And so I think to try to put that on the industry is unnecessary. I do think that if we have a mandate, we'll figure it out, but there certainly, as the mandate stands today, it would be very devastating to the industry because of the differences that we have from location to location, the unfunded portion of this, the availability of staff, all of these issues that have been articulated. It just makes it unattainable as it stands today. That's why it's so important for the industry and those interested in the industry. Use your voice now to be able to speak up for the next, till November 6th, I think, is the date that we have to issue comment back, and it's going to be very important that as an industry we give our voices back to let them know the risk that this poses to those that we care for and those that we employ. It really just discounts when you think about all the other positions that are so key to the care models that we provide, the LPNs that we have in our workforces, all throughout, all of the employees we have that are not being counted in this. It just is kind of a little slap in the face of them, and we're going to have to borrow because there's not enough margins in most of our companies to be able to just add without taking something away somewhere else, with their way they're being so prescriptive about the RNs. And I think the CNAs were probably pretty close to, but the RNs are particularly challenged. We're going to see it's going to impact others. So,
one of the biggest mistakes I made in my career is I asked an RN, or I asked an RN if she was an LPN, and she's like, "No, I'm an RN," and she was very offended by the idea that she wasn't dignified as an RN. And I think the deliverable of this message is also kind of minimizing the fact that there's a lot of LVNs in our space, LPNs, that are giving great care, doing a lot of great things, and quite honestly, they're going to be out of a position. You get a night shift nurse that's an LPN, and we need to have the RN coverage. They're going to find an RN for that. And so I think that even the most well thought out plans or mandates, there has to be a cushion in there for the variability of every one of our locations. And if it's not planned that way from the beginning, what will happen is there will be a lot of fallout until there's enough collateral damage for them to fix it. That's typically the way it works. 23 buildings in Washington lose their, they go out of business and find they're like, hey, maybe we should talk about funding. And next thing you know, after 20 some odd buildings are shut down, let's figure out the funding in Washington. That can't be the case here. There's too much at risk. There's not enough people. There's a lot of problems that we all talked about. There's just not enough schools producing enough RNs right now to even, I don't know if you guys saw the costs in the billions for this change in RN mandate. It's crazy.
Well, it's a great segue into the next topic I wanted to touch on, which was occupancy. We spent time talking about staffing, and the mandate almost suggests it's staff for the sake of. We all know it's staff for the sake of care, staff for the sake of access to care. And what I'm hearing kind of from this panel and from many others that I've spoken with is that staffing is the key to occupancy. Occupancy, in many respects, is, if not the key, one of the keys to industry recovery. So moving to occupancy, and for context, according to the CDC, national occupancy currently sits at 77.6%, just 2.6% below the January 2020 levels. ACA provides additional analysis beneath those reported numbers that show nearly 1/3 of facilities that have occupancy greater than 8% than pre-pandemic levels. That's a good thing. But 1/5 of facilities, so over 3,000 facilities, have occupancy levels that are 20% or worse than they were pre-pandemic. So, Owen, maybe to start off with you, what are the implications of such an uneven recovery and the growing divide between the haves and the extreme have-nots?
Well, I think there's a lot to unpack in that, but like we as a company, we kind of did the burn the boat strategy and decided we're just not going to do agency anymore. The issues that come with people that come in agency are invested in our employees, and that's just too great. So we basically got everybody together, and they all decided, hey, we're just ripping up the contracts and moving on without it. What that does, though, is it keeps occupancy low. We're only going to take patients for what we can take care of until we can train and find these people to come in. And so the problem with that is it puts this pressure on the hospitals and access, and they keep telling us you need to get more, you need to take more people, and we're like, well, sure, as soon as we get staff, we'll gladly take it. And so what I see out there in most of our markets is pent-up demand that's continuing to rise in the hospitals, because we're just not going to go and take, I kind of look at, this is maybe not for the record, but I look at some of those agency companies as fleecing the Medicare dollar. I feel like they're taking $185 for an RN, an hour for an RN is crazy. That's money that should go to the care of these patients, and it's getting fleeced out to third-party agencies. And I don't think that's right. And so for us, we'll pay overtime, we'll work with these people, we'll try to find them organically, but occupancy is going to be low. If you look at the overall occupancy, how many of those people are actually doing that strategy, working on the quality mix as opposed to the number? I don't know. So I don't know what those numbers tell us, but I do think that what's going to happen is an access issue. And especially if buildings are shut down, especially in states like Idaho, in rural locations, people are going to have to drive 300 miles to the next SNF, and home health isn't going to cover those areas. So we've got a pent-up issue that's coming along with this occupancy, and that's just kind of how I look at it. But
We talk about access issues. There's a term I hadn't even heard of before. I guess there's now 30 U.S. counties that do not have a nursing home, so it's known as a nursing home desert. 579 facility closures, according to ACA's Access to Care report that was just published over the past, since COVID, displacing over 21,000 residents. Mike, you operate in a rural state. There's been some facility closures in Iowa. Are there any silver linings to some of the facility closures in the sense that at least the demand side has an opportunity to catch up with the supply side of the equation?
So, sure, there's been a number of facilities that have closed. Primarily, they're financial reasons, right? They're just not able. They get to a point where they're not viable, and there's only so long the ownership is willing to fund that, and then they eventually have to close. I think the census occupancy levels in a lot of facilities are artificially held down because of staffing. I mean, if you're willing to pay the cost, or you have the mechanism to pay the cost, and you're willing to take the sacrifice on quality, there are agencies that will staff you.
and you could take the census. And companies are making that choice. I can't pay that extreme amount of money and still be viable, and it's a little bit of a catch-22. I think the mandate actually could exacerbate that issue if all of a sudden now I've even got to get to a higher number of staff. I've either got to be able to hire those people and afford to hire them, or I've got to even artificially reduce my ability to take census. So I think there are, that's the driving force, I believe, because there's patients out there. If I look at my referral trends, the referral trends are there, the patients are there, you just have to be able to take them.
Yeah.
And so it's catch-22. Can you afford to and want to hire the agency staff to keep the occupancy up, or are you willing to forego that and have a lower occupancy? And it's creating a trend across the country, and it's not just one state, I think it's all states. And yes, in the rural markets, when a facility closes, it isn't like in an urban market where there's 20 facilities and now there's 19. There's one facility, and now all of a sudden the family member's got to drive a significant distance to get to the next closest facility. So it is a real issue in those rural markets.
Well, it's interesting that you think about staffing, occupancy, access to care, all of this with the pandemic, I'm sure having exasperated many of these trends, leads to the changing landscape, or part of the changing landscape in the industry. And I just wanted to, for context, move on to that changing landscape. According to CMS, between 2019 and 2022, the industry averaged 650 chows per year, which was a 60% increase over the historical trends. You think about the iconic brands that existed in this industry for so many years, Kindred, Manor Care, Sava, Golden Living, just to name a few, no longer exist. So, David, from your perspective, what are the puts and takes as a result of this recent change in ownership trends, but also the shift from the larger multi-state national chains to more of the smaller regional-based chains or state-based operations?
Yeah, it's a great question. It's really part of our operational strategy at North Shore. Now more than ever, we need to be nimble, and we've got to be very involved and engaged at the state and local level. And I think larger multi-facility, multi-state operators, that became even a much, much greater challenge. So that's really part of our strategy. I mean, we've got to be very involved with our local legislators, regulators. They need to know us throughout the year. It can't be just during budget season. And we've really doubled down on that, not only as an association, but as an organization where, whether it's PAC contributions, whether it's involvement with fundraisers, involvement with facility visits and developing relationships. It can't be asking for something, and that's when we talk to them. It's got to be people we see, we know, and we've developed a level of trust. But from my experience, to really keep your arms around something, we feel like that sweet spot is that regional operator. Because things are happening so fast and the opportunities for growth and development, that a very large organization, I think, has a difficulty keeping their arms around that. And we have chosen to be that regional operator for that reason. I do want to mention something, Ted, on the previous question. We were I was in D.C. a couple of months ago, and I talked to many staffers and people that were in decision-making positions that were going to be voting and making decisions around the CMS minimum staffing situation. They didn't even understand what it was. And we have to personalize that. One of the stories that I told, and it's imagine a small facility in Wisconsin of 1,000 people. It's a 60-bed nursing home with 40 or 50 residents that employs 80 people. We would have to hire 6 more people at a cost of $400,000 or whatever that number was. They see maybe a PPD or they see broad brush and they're going to sign on because of whatever political party they may support. But when you really bring it local and you tell the stories of what the true impact is, I think that makes a difference. So I can't implore people enough, and it's something we've really tried to do, is we've got to be active. I think in a number of years we've kind of we've played defense and we've allowed things to happen to us, and we can't allow to do it. And whether it's on the reimbursement side or really fighting to get our story out on the minimum staffing, it's got to be all hands on deck. And it can't be a handful of providers that carry that weight. It's got to be everybody within that state membership, and it takes everybody. That 10,000, member thing that's no joke. So I think it's obviously all of our responsibility, certainly within our organization, but mobilizing the bases to tell our story, because it's a really, really compelling story to tell. So,
Lance, is that story more difficult to tell with the changing landscape? I mean, you've been on both sides. You've spent time early in your career with the larger organizations, and now with Cambridge, more of a state-based focus.
Well, yeah, it's interesting. Yeah, I did. I started out my career with Vencor. People remember way back when. But Vencor was a company that was known as a rehab company, and so you could market that. And that was something that was name recognizable. I don't know that happens anymore. I don't think companies can go out and make a name recognizable company. I don't think they want the name recognition, frankly. They don't want the liability or the tie back to a main company. So I think it makes sense to have more localized market presence, also more localized relationships at the hospital and the political level. From a company perspective, it's not even, if you look on our site, we don't even have a website for the company. I think a lot of companies have migrated out of that and now into the facility-specific market, where it means more, and that's where you get your traction from, is the local level.
Overall, is that a positive for the space, Owen, from your perspective?
Well, I definitely think that the more localized approach, if you remember back in COVID, when it seemed like every health district had a different definition of when you could take patients and how long you had to wait, and that on a national level to try to manage every health district across the nation is just impossible. So a lot of people just didn't take meds. They just paused it. And the ones that were more regional and were actually able to make those decisions on a local level, a lot more care was given. People were able to reduce the threshold in the hospital that was hitting up there. And so, yeah, I definitely think that a more regionalized approach is better for the industry. I think it's better for the actual care given. They can sense and see things that are different geographically. Even in the state of Idaho, the difference between Boise and up in Coeur d'Alene is completely different. And same, I would even imagine, even in California, from just different parts of California. So I think that you do have to be active. We did rely a lot on the big chains, if you will, to have advocacy, put money in. And so there wasn't necessarily a need to have a vocal opinion on it. Now, if we don't all rally together and join forces and create that narrative and really form that narrative, then we are going to be just a weak industry, and we're going to be thrown around through all these different changes that are happening. And so it's more important, like David said, now to be active, to make it personal, and make it real about the individual states and individual counties. And on a national scene, I think the AHCA does a great job at that, and I think we participate in that to a degree. But all the blocking and tackling happens at the state level, and if we can't share ideas, work together, we had talked to the panel group about going and heading up the state house together. We'll all, even though I have buildings in Wisconsin, I'm there for you, David, and be there and support each other and help each other. That's, I think, the future of this industry, and if we don't combine, I think then we'll have some headwinds, bigger headwinds than we see now.
That's great, and actually a good segue into the future, the longer-term future of the industry. Who could have imagined that in 2018 we'd be sitting here having this conversation about the topics we just covered? Maybe someone could have imagined it, but it would have been very difficult to predict. And although the next 5 years of the industry is filled with as great an uncertainty as there's ever been, the folks that I'm here on stage with that make up this panel, and many of you in this room, in some way have the ability to help shape that future. And sometimes it's difficult to see or difficult to understand, but if it's not us, then who? So, I'd like to talk about what the future may look like 5 years from now, and it'll give our panelists an opportunity not just to share their visions and their perspectives, but also what they're prioritizing and how they're thinking of what this industry will look like in 2028. So I'll start off with some perspective on the demographic trends. Technology is changing at breakneck speeds. AI is here to stay. And by the year 2030, which is known as the 2030 problem, every baby boomer, all 77 million, will be 65 or older, with the oldest being in their mid-80s. Of this generation, statistically, if you extrapolate the current trends, 4 million are going to need nursing home care. So, Alan, that sounds like a hell of a lot of people who are going to need nursing home care. So with those demographic trends as the backdrop, what does the future in 5 years look like to you?
Well, it sounds like occupancy will not be our biggest problem, right?
Potentially, right.
Yeah, I think that we've all looked for this for most of our careers. I've been in this space for almost 34 years now, so I've been doing it for a long time. And there's no doubt we've been looking forward to this demographic change that's coming and the pipeline that's coming down the road. So we are looking forward to this opportunity to be able to care for this expected need. I think one of the biggest things that's, if I look down the road in 5 years, the data is going to be how do we actually use it? As a company, we've certainly taken a much harder lean in to be able to leverage this data to provide better care. When I started, we used a number 2 pencil, and we did schedules, and we used a number 2 pencil to track things like rehospitalization. And as someone talked on the panel earlier, we're using data now that does tell you all that stuff. It tells you which nurse was covering all the things that they talked about on the previous panel, which nurse was seeing which doctor, what they admitting diagnosis, discharging diagnosis, what they had for lunch, what pills they're on. We track all of that stuff now and are able to put it into a useful form that will hopefully influence patient care and make it better. So I believe that patient care will continue to improve. I do believe acuity will continue to increase. The patients that we are seeing are sicker and younger in many cases, but they are coming to us with more comorbidities. And so the training that we're going to need to provide for our staff is going to be even more significant going forward. I also think it's like what David talked about. In 1988, or close enough, 1988, the top 3 issues will probably be the same top 3 issues in 5 years from now. We'll still be worried about patient care, having enough staff, quality outcomes. And so I think those issues will still be the challenges that we face in 5 years from now.
Great. Thank you for that. David, I've heard you at different times use an ice hockey analogy, more specifically Wayne Gretzky, that like Wayne Gretzky, the industry needs to skate not where the puck is, but where the puck is going. So where the heck is the puck going to be in 2028?
I feel like we've been hit by the puck.
We're in the penalty box?
I wish I had I really like to be strategic, and I wish I had the crystal ball of what it looks like 5 to 10 years from now, and I don't, but I know this. We're not going to be able to continue to go back to our state legislators and ask for more money with the same methodology, and I'm talking specifically about Wisconsin. So there's going to have to be significant payment reform in the states that I operate that's going to be sustainable. The buildings that I operated 30 years ago were 30 years old then, right? And now they're 60, 70. We talked about this in the previous panel. If you have money and you're independent living, assisted living, there are great options. There are things that are wonderful. My father is in one today, and it's wonderful if you can afford to pay. So as we design this future, there's got to be a methodology at the state level that really fosters and values investment in infrastructure. Our physical plants aren't getting any younger, and our residents deserve that. So I think telling that story and making sure we have a reimbursement system that is supporting property investment, I think is going to be critical over the next 5 years. I think we have to continue to pound on the regulation side and the punitive nature and what it is doing to drive away caregivers and specifically our DONs. It's been an incredible challenge, as all of you know, in the COVID environment, and we're losing some really, really good people because they're tired, they're emotional, they have families to care for, and all the things that you folks know. And there are other options for them that are less stressful. So how we can collaborate more with regulators, I mean, ultimately, I believe we want the same thing, but there's got to be some common path and common ground there that is going to help grow, develop, and mentor and retain our leadership. And that's really the last thing. I look at the future with our young leaders, our EDs and DONs, and I can put together all these great ideas or strategies or plans at a senior level or in my office, but at the end of the day, I know if I have a great, stable leadership at our local level, they're able to overcome so many of these things. These are the EDs and DONs that have been in their buildings for 10, 15, 20 years, And it is an incredible challenge for them, but they have overcome this. And I think that's the bright spot, is there are still very many young, willing, able, and talented people that want to be in this business. We need to support them. And again, the last thing I'll say is on any given month, we're hiring about 250 staff. So on that day, at least, they have made the decision that this is the career that they want. And the reality is, after 90 days or 6 months or a year, there is a significant percentage of those that aren't with us any longer. So we spend a great deal of time focusing on recruitment, which we need to, and we're able to open that door, and they're in that chair, that first day during orientation, and for whatever reason, and whether it's culture and better communication, better recognition, and all those type of things, internally as an organization, as a profession, we've got to value them. We have to treat them like gold. I mean, ultimately, it solves so many of our problems. And on day one, they chose us. And unfortunately, on day 90, 120, or whatever, there's a significant percentage of them that aren't with us any longer. So I see that as a big opportunity and part of the solution to get to that 5 years.
Mike, do you see transformation in the future? Is it transformation? Is it more of the same? Are you optimistic, pessimistic? How are you thinking about the not next 5 years necessarily, but what in a steady state we look like 5 years from now?
So I think David said it earlier. If we weren't in the survival mode, and I think most of us are hoping tomorrow will be better than today from a financial perspective, I think there are lots of technologies that we could implement, physical plant changes that need to occur. Dave spoke to that. I mean, we're all in, most of our buildings are 60, 70, 80, 90 years old. We're never built to take care of the patients we're taking care of. And there's absolutely no funding or ability to take some profitability and build new buildings because there's no profitability left. And so, we kind of all thought, well, if we can get beyond COVID, things are going to be better. And now we're facing another new challenge of potentially minimum staffing, which is going to take more wind out of the sails. So it would be nice. I think I'm pessimistic that we're not going to be sitting in the same spot 5 years from now. My son is a techie guy, works for Google, and then we were talking this weekend about all the things we could do, he could do, or companies could do to make things easier, in our space. And I'm thinking, those are all great ideas. How am I going to pay for that? Yeah. If it was free or there was a mechanism to pay for it, great. But when you're trying to survive, it's really hard to think about all those additional things that you could do that would be really good for patient outcomes, would probably at the end of the day produce an ROI, but I've got to fund it in the short term, and that becomes a challenge. So at some point in time, maybe when we're all no longer on the panel and there are other people up there that are much younger than us, that there'll be a situation where we're not trying to survive and to fight another day, which would allow, I think, investment in lots of things that would make the world easier inside of our facilities.
Well said, and I think for me, and I think hopefully many of you, the silver lining to all this are the demographic trends, They're not going anywhere, and that should force better public policy, more sound public policy than what we've talked about leading up to this moment. So with that, I'd like to shift. We're entering the last 5 or 10 minutes of our time together. I'd love to move on to a few rounds of rapid fire Q&A with our panelists, and building off of what we just spoke about, the future and how difficult change can be. Certainly inspiring, leading, and implementing change is hard. So I thought if we could all channel our inner Winston Churchill for a moment and be inspired by him. On May 13th of 1940, Winston Churchill made his first speech to the House of Commons as Prime Minister. It's known as the victory at all costs speech. He famously said, "I have nothing to offer but blood, toil, tears, and sweat." So, Lance, if you could remove the cost of change, all the blood, the toil, the tears, the sweat, and snap your fingers and change one thing about the industry, what would it be in 30 seconds?
Okay, I was going to say in the 1990 period of time when I was administrator, I thought the staff was more engaged. The career staff had been with me 20 years plus. I want that back. But knowing from what you had written on that paper, maybe it didn't exist, but I thought it did. So I want the staff to be career staff, CNAs, nurses who want to stick with the buildings and do well.
Okay, perfect. Alan? If you could remove the cost of change, the challenge of change, and just snap the fingers, what would you change and why?
You know, that's a tough question. I would say that staffing is the primary one right now that I would focus on, and developing leaders and creating career paths for them.
Owen, how about you?
I would change the punitive nature of the surveys. I feel like it's just it's got a negative feel. It's an onerous, strategy is not aligned. And so I think if there was a collaboration on actually doing what's right for the patients and the residents, as opposed to, being punitive to the people that are caring for them and putting their careers out there for them, I think that would change the narrative.
David?
Kind of with Owen. My crystal ball is I want everybody to see the passion that's in this room and is being represented every day in all of our skilled nursing homes, and the value that they provide to the elderly, the people who gave everything in their lives, and we got to continue to tell that story. So my crystal ball is for people to get it, value it, support it, whether it's on the legislative side, reimbursements side, but we got to keep on telling our story because it's a good one, and we can't give up.
I think, if you don't
Yes.
mind, you had mentioned something too earlier, David, about making it personal, and we had talked in a pre-discussion about this, and I think people forget, especially in our states we're in, people love to talk about the education, putting all the money towards that, towards the youth, but once it talks to the elderly, they just don't care so much, right? And it's hard because I think the people drawn to this industry are people that really genuinely care about the elderly people, and these are the same people that built the bridges, taught our kids, or taught our parents. These are all the people who put blood, sweat, and tears into building the dams and infrastructure that we enjoy right now, right? And it just seems a shame that the narrative is crafted in such a way that they're just not looked at as people that were contributors. I mean, the quick story is, I had this lady that came to the business office every day, and she's like, "Where's my money? Where's my money?" She wanted her participation for Medicaid, and one day she walked into our director of nursing's office, and she just kind of sat there, and we're like, "Hey," and she started reciting a poem, and we're like, "What the heck?" And it was like perfect. So we Googled it. We say, "What poem is that?" Googled it, word for word. She recited this beautiful poem and a couple other ones. So in that little short moment of like lucidness, she was able to recite something so beautiful. And then we found out more. She was a dance instructor and all these things, and she was a very big advocate in the community and all this other stuff. That's never told. If we can personalize this and we can rally around that and make it really about the people that we're talking about here, instead of just like this nebulous kind of theory, I think we'll get a lot more traction, because honestly, we're not a huge association. We don't have the money that the hospital associations have. We've got to combat that with real, genuine conversations to get these people to understand what we're talking about.
I'm hearing a million resident march. That's what I'm hearing. But that's part of the limitation too, is because they're unable to advocate almost as individuals, it's left to others to advocate on their behalf. Mike, to wrap up this topic, one snap of the fingers.
Staffing. I think I would agree with the regulatory pressure is there, but for our DNSs, that is probably if you talk to them, that's their biggest issue, right? Because they're one call-in away from having to work, and they're all tired, and they just don't want to do it anymore. And some of the ones that I've worked with, for a long period of time are like, "I'm done. I was talking to a DNS in a building, and she said, "My husband told me that if I have to work another shift, he's going to leave me." Yeah. And I think that's just the reality. They're all, they're tired of missing their kids' soccer games and the play and the school event because the phone rings. They know that probably means they're going to put their scrubs on and go to work. And so nursing management is just wiped at this point in time. So solving the staffing issue would take a lot of pressure off all of them. I think they could deal even with the regulatory stuff if they didn't have to know that they're one call away.
Perfect. Well, I'm going to very tactfully wade in for a moment on presidential politics. There was once a candidate a decade or so ago who ran on a message of hope and change, in the spirit of change. But in a meeting after his victory with Republican leaders, President Obama was quoted as saying, quote, "Elections have consequences, and in case there was any doubt, I won," end quote. Now, President Obama was not the first politician to make a remark like that or to espouse that view, and he likely won't be the last, but the outcome of the 2024 presidential election will absolutely have consequences for this industry. So I'm curious, not necessarily who you'd like to win, but maybe starting with you, David, who will win the 2024 presidential election and why in 30 seconds?
Wow.
Or less?
I'd rather have that hockey question. I think now more than ever, I'm really digging into what their perspective is on policies that are important to our seniors, and I always have. I have to tell you, the last couple of years have been incredibly difficult to see and to watch, with whether it's unfunded mandates or op-ed pieces or USA Today articles that are hammering us, and that isn't doing the profession, it isn't doing our residents any good. So I'm not sure I could put my weight behind any particular candidate, but when I look at candidates, now more than ever, I'm looking at somebody that really supports and drives the type of initiatives and the profession that we all have committed our lives for.
And again, not necessarily who you'd like to win. I want to be clear. It's who you believe will win and why. Lance, do you have a view on this?
Wow.
We're tapping out.
Yeah.
That's why I have Mr. Mike Beal sitting to my left. I'm hopeful that he will give an opinion.
I don't know there's a good option, frankly. I don't know that either of them are good options. But I think from who I think will win, I think Biden will win only because Trump is despised. That's about the only reason.
Mike, who do you believe will win and why?
I agree for the same reason. I mean, Trump will win the nomination, but not win the general. And it's probably the worst outcome for our industry because we're already going in a direction of we're going to beat people into providing quality of care, and it's going to be more of the same. I think the mandate will charge forward. I think regulatory pressures will charge forward, and we'll see more of that. But I think that's a sad reality, and that's what I would agree.
Owen, Alan, any comments, any thoughts on who will win and why? Owen, maybe starting with you.
Yeah, I was thinking dark horse. I saw Rick Matros walk in here a minute ago. I think he was going to put his hat in the ring. Maybe I'm jumping the gun there a little bit. Yeah, I don't know, but I think whatever happens, I hope the rhetoric is subdued a little bit. I think that it's such a divisive, process it seems to be now that we need time to breathe after COVID and all the chaos. I think people are tired of the political side of stuff. We need to get back to a little bit back to the basics. So I do think it's hard to. It would be hard not to see Biden, who's already got the presidency, not continue with that.
It's hard to beat an incumbent.
It's hard to beat an incumbent.
History would suggest.
So, yeah, I would generally say that.
Alan, any final commentary?
You know what, of the two leading candidates we have to choose from today, I think America loses. Certainly our industry loses right now where we're at. I'll just be different, just to shake it up. I'll say maybe there'll be somebody that, I think we have real health issues on one side of the party, and I think the other one has a lot of drama. And so a lot could change between now and the election, and maybe that would come through and be a better option for all of us. So.
Perfect. Well, we're right on time. We've got another minute or so, so we're going to end on a bit of a lighter note. This is our final rapid-fire Q&A question. This next topic has gotten some recent buzz in the media, Congress, and it even made its way into the first Republican debate. But with the recent spike in UFO sightings and the possibilities of extraterrestrial life, there's a growing concern among politicians and industry leaders that we may not be prepared to care for what could be another aging demographic, the ET boomers. So I have to ask, this is just a yes or no question. Owen, do you believe in extraterrestrial life?
Of course I do. Like I mentioned at preface, Rick Matros is here. He came to us in the industry a few years ago to kind of set the stage for this, so absolutely 100%.
Alan?
We're trying to recruit some now.
David?
I don't, but something tells me I'm going to see one tonight.
No offense taken, right?
Yeah.
To anyone in this room. Mike, how about you?
I would say no unless there are ends.
Lance, bring us home.
I think there absolutely are life out there. Yeah, no doubt.
Fantastic. To be continued for sure. Well, look, I think this was an outstanding panel, and it was a real honor for me to be part of this in a small way. I think some of the takeaways from our time together, there were many takeaways, but certainly, in the first, let's say, half or so of our panel, we talked about the near-term opportunities, the near-term challenges, and for me, this idea of occupancy being central to the industry recovery, but staffing being kind of the base of that really came through. And what else I heard was short-term fixes aside, and there were some very good ones discussed here. The long-term solution is pretty traditional. It's grounded in solid public policy and things like leadership and culture, and that's really the focus, and improving or increasing the supply side of the equation. In terms of the future takeaways, data playing a bigger role, AI certainly playing a role, but again, the recipe for success in the future will be people first, and it will remain the sentiments of the panel, people first business, so plan accordingly. And then finally, I think key takeaway number 3 for me was that rapid fire is awesome. So I appreciate you guys being good sports there. So, hey, thank you everyone for coming, and have a great rest of the night.